I'm Dr. Jay Anders, and this is Tell Me Where It Hurts, where we discuss some of the big challenges in health IT and how we can solve them so clinicians can do what they do best, care for patients. I'd like to welcome everyone to another episode of Tell Me Where It Hurts. Today's episode is dealing with kind of an interesting topic it's gotten more and more traction over time, and that's how precise now pharmacy and pharmacy treatments are becoming more and more focused. So, and then how does that relate to IT data in healthcare systems, and how can we leverage some of that? And when looking at this, I was looking back over my career, and I remember the old big book of pharmacy drugs that we used to get, the PDR. And when I started, the PDR was probably, really can't see me, but it's about 2 inches in depth. And then it got a little bit bigger, and it got a little bit bigger. And then I remember it coming in 2 monstrous volumes with all kinds of supplements that came out once a quarter, and especially if anything had a black box associated with it. So trying to keep up with all of that in your head as a general internist was darn near impossible. And when it came to things like doing drug interactions and focused therapies, finding what you needed was not that easy to do. But since the advent of computer systems and EMRs and things like our guest is a part of, it's become a whole lot easier, and I think has advanced healthcare very quickly and rapidly over the last several years. So without any further ado, I'd like to introduce Dr. Anna Dover. She is a PharmD, is a healthcare technology leader with more than 20 years of experience spanning clinical pharmacy, decision support, and healthcare informatics. She's Senior Director of the Editorial Content of First Databank, and she oversees the vision, strategy, and delivery of trusted clinical content that powers decision support solutions from FDB. She had up through the ranks type of training where the staff pharmacist and just kept going and kept going. I would call it in trenches, especially a hospital pharmacist workload, which is could be really tough. So she got her PharmD from the Ohio State University and started down this road with decision support and healthcare informatics. Anna, welcome to the program.
Thank you, Jay. Thanks for having me today.
Well, this should be a fun conversation. First off, can you tell us a little bit about your pathway? I mentioned it a little bit, starting in the trenches and working up, which is a lot of us did that. So tell us about your journey in getting into the position that you are now.
Sure. Yeah. So I did start out in direct patient care. I was in pharmacy management a bit too, and hospital pharmacies. I really got the clinical bug when I was in pharmacy school. I started out working in retail. I actually worked for Revco, so that tells you how long ago I was in a retail pharmacy. I loved working directly with physicians, rounding on patients. That clinical care was very fun. And over time, I really spent my time in critical care, which I found exciting and enjoyed quite a bit. But over time, EHRs were really starting to become part of the health system infrastructure. So I moved over to informatics with our implementation of an EHR at a health system in Wilmington, North Carolina. Our CMIO was actually an intensivist I worked with, and he knew I had worked with EHRs at prior hospitals. So he asked me if I would consider coming over to help build the EHR and deploy it. And that was a very valuable experience. That's when I started working with FDB data. I was loading the data in the database. I was leading the team that was designing and deploying custom decision support at the health system. And it was nice to have those relationships already with the physicians as you do that, because as you know, it is challenging to deploy software. There's standardization that comes with it that folks may not realize. There's significant impact to clinical workflows, so it's really important to understand that to do it well. And make sure you redesign. So I really started out building on that EHR side. I joined FDB a little over 9 years ago. I started out on the product management team, and had a lot of fun there, designing some of our newer solutions, working on things that optimize decision support, made it more specific, patient-centric, worked on our pharmacogenomics product as well, looked at some reporting pieces, analytics, and then I had an opportunity to come over to the content side of the house, which is really the foundation of what we do at FDB on the editorial side. And so I did that. I think it was August of last year I moved over here, and I'm really enjoying it. It's new challenges, and I feel like it's almost like coming back home to pharmacy in a lot of ways, because it feels a lot more like the days when I was in the pharmacy and more directly in that patient care side of things.
So tell me a little bit, what is editorial content? Can you define that for us so we can have our listeners know what it is?
Yeah, sure. So I think of our team as the data acquisition team. So my team is in charge of identifying and adding new drug information to the database, the way that it's structured so that it can be used in all the different systems that FDB content is used in. There's classifications. When you think of how it's deployed, you think of things like bedside barcode scanning, ordering of a drug, prescribing of a drug, dispensing of a drug, billing, that identification, and then thinking of reporting on the drug and various systems throughout. So that's really what my team does. And then that's where it all starts. I think of us as the cornerstone of FDB's products in general, actually.
That's very interesting, because the one thing that a general internist does 100+ times a day is write prescriptions. And having all that information at the point of care is so important, especially now. And we'll get into this in just a moment. So EMRs have now, as I talked about before, has developed clinical decision support as it pertains to pharmaceutical treatments. And that has expanded, quite some bit. And if you look at what's advertised on television, and that's a kind of a pet peeve of mine, but what they actually are producing, a lot of these are all biologics. It's amazing the targeted therapy now that is out there. And most recently, all of a sudden, pancreatic cancer is not 100% fatal anymore. There's targeted therapy for that now, which I find absolutely wonderful, because I had an aunt die of pancreatic cancer. So it's now almost treatable, which is great. So you've worked on clinical decision support, and how do you marry up the data that you need to do that kind of work and what you need to actually feed back, and at what part of like the workflow for a particular clinician?
Mm-hmm. Yeah, I think that is one of the great challenges, right? Because we designed something that could be used in an interruptive fashion. You could interrupt a clinician. So we really need to be thoughtful about when we do interrupt a clinician, when it really matters, when we guide them, when we nudge, versus when we completely stop someone. And so the way that we do that, you need to make sure that it's the correct drug, of course. So you wouldn't want to alert on the wrong drug and give misinformation. You could lead someone down the wrong path. But then also, you have to put some kind of toggles in there. So different organizations can decide what's most important. Different practice settings, it becomes very important. So, what an oncology clinic may want to see versus not is very different than a cardiology clinic. Or for you as a general internist, I think you would probably want to see maybe a little bit more versus some of the specialists in their various areas. So I think that's one of the ways that it becomes really important. Also, understanding how it performs out in the wild is an important part as well. So we as a company really take a lot of time trying to collaborate with our customers, getting the feedback, getting the inputs, understanding when things change, whether it's clinical practice or when a system change happens. Sometimes unintentional things can happen when there's just a system software change, for example, of how something may perform. So these are all considerations as we curate the content, as well as when we make changes out there for our customers too.
So talking a little bit about alert fatigue, and when do you actually alert someone, when do you put a hard stop on someone, how do you get the feedback to really make because it's a balance. It absolutely is a balance, because you can get alert fatigue very quickly using some of these systems. So you're laughing because we know exactly what that is. So tell me a little bit about how you design that, or how you meander that little morass, because it's a spectrum of what you need and what you don't need.
Yeah. So I'm going to share a personal story just from early in my tenure in informatics. So pre-FDB days, it was early in my EHR journey. And, I came out of the ICUs. And one of my challenges working in the units was when a patient would get started on a neuromuscular blocker and not have appropriate pain management and other supportive care that needs to happen. And you'd be shocked at how often that happens. And so that was one of my things. I ran around the units, like making sure that that was done, making the case for why the patient needed it. And so I was able to get an intensivist to sponsor an alert to identify those patients when they didn't have that appropriate supportive care and flash the alert, and it would allow them to directly order the appropriate order set to provide that care. And I went back to review how it performed over time, and it was not accepted. It wasn't being used. So exactly, right? I see your face as I tell you this, where you're like, wait, why wouldn't someone do that? It's the right thing to do for the patient. So then I went into the system with one of the physicians, and I realized I had it popping up as soon as the chart was opened. So it was a very appropriate alert. It was the right thing to do. There was nothing clinically wrong with it, but it was at the wrong place in the workflow. And so I think that's one of the things I learned early in my tenure, right? I had an alert that I designed years ago that was a hard stop for a flu vaccine. And it was something that organizationally it was determined hard stop. That patient cannot discharge without flu vaccination on discharge. But people still found a way around the hard stop. It was amazing. And I had to do digging into the EHR to figure out how they were able to find a workaround workflow. So all of that is to surmise that I think, my theory is often the best decision support is passive. And we very often design content to be used in a passive fashion, not just interruptive. And the core of it is understanding, the workflow, the clinician and the needs of that particular clinician, their specialty, and being very judicious with things like red and stops and things that can really interrupt or interfere or become just noise that no one sees anymore. I think it's really that's one of the most important parts in designing that decision support.
Interestingly, you say passive is the way to go, because one of the biggest complaints I've ever had about EMRs in general is something that stops me as a clinician from doing something. You're done. You've got to do this. You can't do anything else. That is a red flag. Everybody hates that. Give me the information. I need the information, but don't stop me from moving on if I want to move on. I think that's such a great lesson that we've learned over time, basically. Yes. And then when it comes to pharmacy, well, I'll tell another little anecdotal story. Back in the days before there were EMRs, I had a program that did drug interactions. So you just entered the drugs in and you got a little sheet back of this interacts with that. I had a patient come in my office with 3 grocery sacks full of medications. And it was a tremendous number of drugs. I said, are you taking all these? Oh, yeah. So I had my nurse give her the bag. She entered this all into that system. And I got 4 full pages of interactions out of that. And he asked me, well, why do I feel so badly? Well, I'll tell you why you feel so badly. You're on so many drugs. And now the way we do it is you get that right up front. Before you even send the prescription off. That is such a small, however, very important example of what you're talking about. So that, we have advanced, thank goodness. Let's move a little bit into genomics and pharmacogenomics, which is something you've got some experience in. And I'd like to talk about that in conjunction with data that are in medical records that needs to be transmitted and or received or otherwise worked with. So first off, what is pharmacogenetics? Can you give us a little background on what that is?
Yeah, I think that the easiest way to describe it is to think of the ability to look at a patient's genetic makeup to determine if certain drugs could be impacted by their particular genetic makeup. So, when you think of differences in how drugs are metabolized in the body, you can see patterns in the general population, but it's usually you're basing it on patterns such as ethnicity or gender. But now we can actually look at their genetic makeup proactively to determine if there may be an ill effect from a drug, or a drug may be less effective, for example, based on that genetic makeup. Yeah.
So turning to the data side of that, tell us a little bit about what FDB is looking for to help tailor that response, either a responder, non-responder interaction or whatever. So tell us a little bit about the depth of data that's necessary to actually accomplish this kind of thing.
Yeah, so we as a company had explored pharmacogenomics long before I joined FDB. We'd even partnered with some genetic testing labs. And what we determined over time, and in collaboration with customers, was we needed to focus on the drug and interpreted genetic test, meaning we didn't need to get as specific with the star alleles, for example, because when you get into things like that, different geneticists may disagree on what the full impact will be to a patient. That science can constantly evolve. The testing panel used can determine what level of interpretation you can do for impact to a patient. So we really focused in on the phenotype, or the I'll say physiologic manifestation of that genetic variation, and the confluence of that with the drug. And so when we integrate with EHRs, we are receiving primarily phenotype level information about that patient and their drug list, and then identifying if there is a drug of concern related to that variant in the patient's physiology.
So I'll try to define a little bit what that means. It's not, the phenotype is actually what the signs are, what symptoms you may have, things like that. There's a lot of data. It's not just a gene, it's what the body is doing with that. So when a physician's taking a history, there are certain history items for that, certain physical findings on a physical exam, certain reactivity to tests, different tests. So it's a broad set. So right now, it seems we're in this whole interoperability phase where everybody is sharing medical records all over the place, and some are being used, some are not being used. Tell me some of the challenges you see in that, because a lot of that data is not really granular enough to make decisions on.
Yeah, I think that's a great point. So a lot of genetic information is locked in a PDF document in an EHR, right? It's not structured, it's not available. We actually, I talked about our phenotype level. We do have mappings out to genes and the star alleles. We can get to that level of information when it's passed to us. But one of the challenges in this space is there's not really a standard vocabulary for transmitting this information. There are some specifications out there. HL7 has some around fire. Some of the vocabularies you have, like PharmGKB and CPIC, you have SNOMED CT, you have LOINC, but no one code set is comprehensive across that genetic marker. And so that's part of the challenge. I mentioned that things can change over time, the science can evolve. So imagine an interpretation locked in a PDF document. It doesn't get updated. So that's a bit of a challenge as well. And then patients can have additional genes tested later that will change the interpretation at a phenotype level from what it was previously, because there's a certain level of specificity that can confer based on how many genes were tested. So it's an interesting thing. It depends on the panel, frankly. And that's not standard. It depends on the lab company that's doing the testing, what panel they will offer for your patients, frankly. So that variability can make it more challenging. But it's still an exciting time because the science continues to evolve, and there are a number of genetic markers that have very compelling evidence to use right now, and really should be tested and reviewed before starting a patient on a therapy, for example, that could really help improve quality of life, improve time to efficacy, or prevent safety issues, frankly. So it's a balance, and I think some of it is because it is still an evolving science. I mean, this was the promise when I was coming out of pharmacy over 20 years ago, and so it's pretty cool to see it actually in clinical practice now. I mean, that's frankly pretty rapid for healthcare, I think, to have something really moving into practice within 30 years, that it's gonna, I think within 30 years it should become part of just our core clinical workflows, which is pretty exciting.
Well, you see all these advertisements now for getting your genetic makeup done, and makes you look, well, I've got a propensity for colon cancer, I'm carrying the BRCA gene, or I'm doing some of those, and people are doing those on their own. Do you see from feedback from your providers and the people you supply your program to, that kind of stuff coming into play?
I think most sites are not adjudicating that into the EHR necessarily. I think you always have to know the caliber of the lab, and it could be an excellent lab that's doing that type of testing. But I think it is, I think any practitioner, if a patient brings something in, is going to be looking at the source of the information before they actually file it into the permanent medical record. So I think there is a place for it. But then again, you get into, very often it's an interpretation that patient's carrying with them. And again, the science can evolve. And so is that interpretation still true 5 years later? It very likely might not be.
So what other challenges do you see in this realm regarding, the clinician, patient benefit, the new world of sharing data like we talked about? Because I perceive that someday there's going to be some standard testing that everybody's going to get, just like you get the CBC today. You're going to get a certain battery of genes. Unfortunately, one of my family members had breast cancer. It was very early stage, but all that testing went along with that, along with her family. So when you see that being incorporated, what are some of the challenges you see in that?
Yeah, I think, well, first and foremost, thinking about clinicians and patients, but in particular clinicians, it's hard to keep up with this. It may not apply to their specialty. This information is constantly evolving. You may not have been trained very heavily on this coming up. And so I think it's new to practice. So figuring out how to deliver the information in a way that meets their needs at the time and the level that they need, right? So one of the things we do is we actually have hyperlinks within our content that we provide, so the clinician could go to the source material. Because most physicians, if you throw an alert at them, well, they're not going to take it at face value unless it resonates with something they've already learned. So they're going to want to go look at the core evidence, right? So we give them links to CPIC and other sources for that evidence, so they can go look at it themselves. So it's part of their learning process. I talked a bit about the lab panels and the variability there, and then even that clinicians may not agree on the interpretation. That's one of the challenges. When we think about interoperability, this information really doesn't change over time. And there are some ethical considerations, I think, in that exchange of patient information. The patient may not want that information exchanged in a way that's different than a potassium lab, which is transient, right?
Yeah.
And I think that's something we have to think about, because ultimately this is not an FDB opinion, my personal opinion is the patient data is the patient's data. And so I think there's something we need to be cognizant of as a community on what we exchange and how we allow them to have control over that information.
That's a very, very good point, because there's some studies out now with this new ambient technology of listening to conversations in the exam room, and it's producing data that some of it's kind of scary. 80% of those summaries contain errors. And do you perceive this as some of the gotchas we're talking about here, where something gets in that medical record that could be interpreted differently, and it may be wrong? So yeah. What do we do about that? I know you're not an expert in that, but when it comes to what we're talking about here, the preciseness of the data really drives everything else.
I think that's a great point. I will say, I don't know that that's new. I have seen that, when folks would convert to an EHR, they may hire abstractors. And I have seen where I know of friends that something was abstracted into their chart, and then they would try and get it changed, right? They would see it in their patient portal, And it might take them a while to get that information changed. They may have a diagnosis put on their profile that wasn't true, right? But it was just that conversion over. So I think we had issues in the manual days as well. And I don't know that we had. I think it could be more challenging than it needed to be to get things corrected, frankly, when something was in a chart. So I think it's a good point to bring up. I think it's also a time of opportunity, though, with some of the technologies we have now that as they evolve, they can help us identify those things as well. This doesn't add up. One thing is not like the other. And surface it for a clinician to review, have the conversation with the patient. So I think there's risk, but there's opportunity with it as well that can really help, that larger pattern recognition and identifying anomalies so that you can, have the conversation and ultimately resolve it to go forward.
Oh, absolutely. I'm going to roll back to a little bit about the privacy issue about exchanging some of this data. And we didn't talk about this directly, but some of this genetic data that's out there can really affect people's lives, not just their health. So if they go and apply for life insurance and you're BRCA positive and your grandmother's BRCA positive, it's all there. What's the insurance company do with that? What happens to you as a person and all the other aspects? Some employers would look at that kind of thing. So I think your point's well made about the privacy part of this and being able to say, no, I don't want that going anywhere. And how do we stop it?
Yeah. Yeah. I mean, if somebody had HLA-B 5701 tested, it was likely for an HIV antiviral, right? Mm-hmm. So just the idea that they had that test and that result is passed could be indicative, right? And I think it is something we need to consider in how we allow them to have that privacy. At the same time, there's a whole segment of healthcare that is kind of cut out of this, and sadly, it's the pharmacists. So while they may have access in a health system, in a dispensing pharmacy, the ones that are directly there and are not, those patients aren't going to have the same type of monitoring and follow-up that an inpatient does. Absolutely. They're not getting this information. It's not part of the e-prescribing pathway, right? It would have to be someone from the health system sending that information proactively. And that is a gap. And there are drugs that it would be pertinent. And then they face the conundrum of well, do I ask them? Is it appropriate for me to ask if they've been tested or not? So, there's multiple angles to look at on we need increased transmission, but we also need to be cautious and respectful of the information that we exchange as well.
What you say is very, very true, because one of the things as a general internist, I could look at a medication list and I could almost down to the disease tell you what that patient has, just looking at the meds itself. So yeah, it becomes very, very important. We're kind of coming up on the end of our time here. Is there anything else you want to talk about as far as FDB, and there are any new initiatives that FDB is doing?
I think, as a company, we've really been focused for the last several years on making information more patient specific that we surface. So things like genetic tests, bringing in lab information, considering diagnoses, mitigating factors on concerns, for example, and just getting more targeted and specific with the decision support and the content that we provide. So I think it's an exciting time. We're also really rapidly evolving as a company, and we've been exploring AI for pretty much since I joined FDB. This time of rapid change is interesting as the tech evolves and everything else. So we as a company are trying to make sure we're prepared with the tools folks need for it. We launched an MCP recently, which is, I think of it as an API designed for LLMs, for example. So the idea that we can help ground and provide a good source of information for an LLM. So it's not just pulling something off of, a website. It's not just web scraping. It's actually using evidence-based, clinically curated information. So that's exciting as well. It's really an exciting time to be at a content company and reimagining how we do things with all of this new tech. So, yeah.
And it's moving at light speed, just like you said. It's crazy how fast this is evolving. Well, I ask this of everyone on my podcast. If you could change one thing in healthcare, just one, what would it be?
So I'd say I would reduce the friction clinicians face just in clinical care today. I think, though well-intended, very often healthcare technology can create cognitive burden. It can make it harder to care for the patient, which is not the intention. Very often it's intended to help make it easier. Personally, that's what motivates me is, how can we help support the best clinical decision making for the patient in a way that makes it easy for the clinician to do the right thing and make it their easiest choice for that patient. So that's really what drives me, Jay. And I was kind of excited for you to ask me that question, actually.
Well, let's work towards that because that's one of my goals too. If someone wants to get a hold of you or contact you, how would they do that?
Well, I'm on LinkedIn. My email is adover@fdbhealth.com. And so it's a pretty easy one to identify. I attend quite a few conferences. I'll be at the, NCPDP happens 4 times a year.
Thank you so much for being a part of our podcast. I appreciate your time, and I think our listeners will enjoy what we had to say today.
Well, thank you for having me, Jay. I really enjoyed the conversation.
That's all for today. Thanks for listening to Tell Me Where It Hurts. Tune in to Healthcare Now Radio and Podcast Network each month for the latest episode. To learn more about Medicomp systems, visit our website at www.medicomp.com. You can also follow us on Twitter at MedicompSys or myself at MedicompDoc, or check out the show notes for links. See you next time.